Yes,
So, with all due permission, sir, I'm starting with today's live now.
yes,
Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this event. And the focus of today's session is general anesthesia. And now, I would like to invite Dr. L. Meenakshi Sundaram, sir, our distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of Indian Society of Anesthesiologists and has held key positions including governing council member, president and state secretary of the ISA Tamil Nadu state branch. Now sir, we can proceed with the session. Over to you, sir.
Thank you, Clarinet, for the opening remarks. Now I am very happy to invite all of you to participate in our 43rd webinar of Puthukkottai Bhudhan second edition. And this is the right time I should recollect the 42nd webinar of Puthukkottai Bhudhan second edition was held on 5th November under the theme Non-Operating Room Anesthesia, NORA. And the faculty were it is a pan-India faculty. That's I want to emphasize on that pan-India faculty because the postgraduate was Dr. Sagi Harmita from NRI Institute, Visakhapatnam, Andhra Pradesh. And anesthesia in radiology suits was dealt by Dr. Nilesh Nafde from Ratnagiri, Maharashtra. And anesthesia for endoscopic procedures by Dr. Indubala Maurya, who is an associate professor in Kalyan Singh Super Speciality Hospital, Lucknow, Uttar Pradesh. So one is from Andhra, another is from Maharashtra, another is from Uttar Pradesh, and it was moderated by Dr. Amuda Rani, who is a Dean, Government Ramanathapuram Medical College, Tamil Nadu. So 4 states participated in that, and most of the time, I think 6 or 7 times we had that Pan India, and today it is Bangalore. Bangalore tops the list of participation in the Puthukkottai Bhudhan second edition. People are interested like anything. Then Karnataka, Bangalore itself has participated in more number of webinars, and even many people are waiting in the pipeline. So that enthusiasm, I salute and welcome this sort of enthusiasm from the people. And this time, the junior most faculty is Dr. Shreya Hegde. I know only the Chief Minister Hegde. Now I know the Shreya Hegde. She is a junior resident. She is doing her third year in Bangalore Medical College and Research Institute. And she has done her UG in Shivamoga. It is now called Shivamoga. Previously, it was called as Shimoga. I think she has done it in Shivamoga Institute of Medical Sciences. And more than intelligent postgraduate, she is interested in singing. So I don't know how she's going to sing. She can sing a song for us, and she is interested in doing pencil sketching, and she's interested in painting also. So I think it is drawing. You do a pencil sketch and paint. I don't know whether that painting means house painting or this diagram painting. I don't know, but she has mentioned it specifically. She's interested in pencil sketching and painting. Why I am elaborating on this? Sometimes the Puthukkottai Bhudhan will act as a free matrimony for the participants. So this time we want to emphasize Dr. Shreya is an eligible bachelor and she is an intelligent postgraduate, and everyone knows she is a good anesthesiologist. So she can anesthetize anyone at any point of time. So that's what I want to emphasize, and it will be followed by Dr. Chandrakala. Dr. Chandrakala is a MDDA graduate, and she has worked in the field of anesthesiology, and she has gained more than 15 years of teaching experience. And at present, she is working in Bangalore Medical College and Research Institute for the past 8 years. And he has been a party in all the conferences organized in Bangalore and across Karnataka. And madam is interested in obstetric anesthesia. Her PG is interested in pediatric anesthesia. So they go together. So she's interested in obstetric anesthesia and she's interested in ICU. See, usually females taking interest in ICU is very, very rare because it is a time consuming and demanding specialty, and she's looking after ICU also. And she's having two publications to her credit. At the young age itself, she has done that. And she's presently preparing a research project in developing innovative concepts in healthcare. Even I have been nominated for the Chief Minister's Award for innovations in healthcare. So I love to hear that she is interested in that. But more than that, she is a qualified yoga teacher. So she can anesthetize by means of anesthesia as well as by yoga and by literature also. When I am interested in Tamil literature, fortunately I have written 11 Tamil poetry books and I have been adjusted as a Tamil scholar by the government of Tamil Nadu with a cash prize of 25,000 rupees. So I am the only doctor who has been awarded a Tamil Scholar Award by the government of Tamil Nadu. And I am very happy to see Madam is interested in Kannada literature and English poems, and he has written more than 500 plus poems and recited many poems in the functions. So she is interested in singing, dancing. So that goes together. She can sing, she can dance, and many people will dance to her tunes. So that is her extracurricular activity. And she is going to talk about the inhalation agents. Hope it will not be volatile in our brain. And it will be followed by Dr. Sumaiya. So Dr. Sumaiya is also working as an assistant professor in Bangalore Medical College. And Madam is having keen interest in the teaching programs of anesthesiology. So that is quite nice to see. Madam has so many credits. So she has done her DIP and B from Kidwai Memorial Institute. Usually we know DIP and B is the toughest than MD because the examiners will be tough in DIP and B. That is the reason why people are joining, because MD it is assured pass. If you are working for 3 full years sincerely, you pass. But she is a DIP and B graduate and she has done her MBBS in Davanagere, and she is interested in teaching UG as well as PG. She is conducting as an assistant professor. She is good at conducting ASCIIs and supervising OT, ICUs, everything. And she is a senior resident in Bangalore for 7 years, and she is good at anesthetizing patients. And her areas of expertise will be regional anesthesia, difficult airway management, perioperative and ICU management, pain and palliative care, and onco anesthesia. So I think she can go for DM onco anesthesia. And the peculiar point is we will be interested in reading storybooks as a hobby. But her hobby is reading only medical books. I don't know what it is a hobby. It is a curricular activity. But at the same time, she is interested in meditation. That means she will anesthetize patients and she will meditate. So both will be anesthetized. This side and that side, God will take care of the patients. And the surprising part is she is interested in cooking. Nowadays, a lady cooking itself is a very big news. A lady doctor cooking is a very, very big news. And a person interested in cooking but she is having it as a hobby. Hobby means at times you will do, probably once or twice in a year. You will do. So madam is interested and she is interested in music and photography. So with all these stalwarts are there, who is going to control all these people? Three great ladies, just like Saraswati, Lakshmi, Parvati. So we want some Mageshwara to control all these people. So we have fixed up Dr. Raghavendra, who is associate professor in their own institute, so that these people will dance to his tunes, whether he is singing or not, because he is associate professor there, and he will control them also. So he is good at simulation. So he is a faculty in all simulation centers in ISA conference as well as ICA conference. So he is a faculty trainer and a speaker in various conferences. And his area of interest are pediatric anesthesia. Probably Shreya got that from him only, interested in pediatric anesthesia. He is interested in neurocritical care, regional anesthesia, and monitoring under anesthesia, naturally simulation in anesthesia. because he is going to simulate how a webinar could be now. So his extracurricular activities, see, by his appearance in the t-shirt, we know he's a good cricketer. But unfortunately, he has joined medical profession. If he has been a cricketer, for a match, he will earn 1 crore. So he has left that so that other people can live in that cricket, and he has joined, and he's a traveler. Previously, we used to say he's a roadside Romeo. If you are roaming in the street, now the dignified term is he's a traveler. So he travel length and breadth of the country, and he is interested in trekking. So anesthesiology is also just like trekking, because it is very difficult to anesthetize and successfully come out of the patients to be brought out of anesthesia. So he is doing it perfectly well. And now the battlefield, not a cricket battlefield, the webinar field is open now. And now, Dr. Raghavendra sir, it is your time to play. Please take it over. Thank you.
Yeah. Thank you, Meenakshi Sundaram sir, for such a witty, humorous, and lively introduction of all the faculty for today's webinar. It was pleasure and I'm honored to have all those our postgraduate and our colleagues to have this webinar, and it is very uh, happy to see that Bangalore has become very favorite of you to have a webinar conducted uh, without undergoing some more time. I'll introduce my postgraduate to present her first topic, which is around about the Bain circuit and its modification. Yes, Shreya, it's up to you. And also, I thank our head of the department, Dr. Netra, and senior professors and other colleagues to have faith in us and having allowed us to have this webinar. Thank you. Yes, Shreya.
Good evening, everybody. I'm Dr. Shreya, Junior Resident from Department of Anesthesiology, BMCRI. Before starting, I would like to thank Meenakshi Sundaram sir for giving me this opportunity to um, present, and also Dr. Netra S ma'am, our professor and HOD, Department of Anesthesiology, BMCRI, and of course Dr. Raghavendra sir, Associate Professor, BMCRI, our moderator for today. I'm going to talk about Bain circuit and its modifications. To begin with, what is a breathing system? A breathing system is defined as an assembly of components which connect the patient's airway to the anesthetic machine, creating an artificial atmosphere from and into which the patient breathes. It consists of a number of components. This includes a fresh gas port, a port that connects to the patient's airway, a reservoir, an expiratory port through which the expired gas is vented to the atmosphere, flow directing valves, and corrugated tubes which act as conduit between all these other components. Broadly speaking, these breathing systems are classified into breathing systems without carbon dioxide absorption and with carbon dioxide absorption. Today, as we're speaking about Bain circuit, that is a breathing system without carbon dioxide absorption. Mapleson classification, it based on how the different components of the breathing system is arranged. Mapleson has divided the breathing system into 6 different types, named A, B, C, D, E, and F. Today we're going to be talking about Mapleson D. It is a breathing system without carbon dioxide absorber with reservoir in the efferent limb, in which the fresh gas flows at the patient end. It has a T-piece near the patient end. Now, T-piece is a 3-way tubular connector in which one is a patient connection port, one is a fresh gas flow port, and another port connecting to the corrugated rubber tube. Now, Bain's circuit is a modification of the Mapleson D breathing system. It was introduced by Bain and Sporrell in the year 1972. In the Bain's modifications, the fresh gas supply tube runs coaxially inside the corrugated tubing. The outer tube is attached to a mount which is connected to the reservoir bag and the APL valve. The outer tube is transparent so that the inner tube can be seen for any disconnection or kinking. The outer tube has a diameter of 22 millimeter and the inner tube has a diameter of 7 millimeter, and the entire length of the tube is 1.8 meters. And the corrugated tubing capacity is 500 ml, that is approximately 1 tidal volume. So diagrammatically, this is how a Bain circuit looks like. It has a fresh gas flow port which enters and runs within the outer corrugated tubing. This is the fresh gas flow which runs within the outer tubing, corrugated tubing. And the outer corrugated tubing has a mount which is connected to the APL valve and the reservoir bag. During inhalation, the patient breathes in air from the inner tube as well as the outer corrugated tube. The inner tube supplies the fresh gas flow. During exhalation, the expired gas runs in the outer corrugated tubing. During exhalation, fresh gas flow continues. So there is mixing of both expired gas as well as the fresh gas flow. So the outer corrugated tube contains a mixed composition of both the expired gas as well as the fresh gas. So what are the benefits of coaxial tubing? It provides a self-contained, thermally efficient atmosphere where inspired gas is naturally warmed. Because the outer corrugated tube contains the expired air from the patient, the fresh gas flow which runs within the inner tube gets naturally warmed from the heat in the expired gas. Also, since during inhalation, the patient breathes in air from both the outer tube and the inner tube. The outer tube contains expired gas, which is humidified expired gas. So because patient breathes in the same gas again, there is some amount of humidification as well. The functional analysis of Bain circuit. So during spontaneous respiration and controlled respiration, how it happens. During spontaneous respiration, the APL valve is kept fully open. During exhalation, the exhaled gas mixes with the fresh gas in the corrugated tube. And once the expired gas completely fills the system, the excess gas is vented out through the APL valve. During expiratory pause, the fresh gas continues. So it fills the corrugated tubing to some extent and pushes the expired gas with carbon dioxide from the corrugated tubing. During inspiration, patient inhales fresh gas from the fresh gas inlet as well as the mixed gas from the corrugated tubing. So if the fresh gas flow is high, all the gas drawn from the corrugated tubing will be fresh gas. But if the fresh gas flow is low, some exhaled gas containing carbon dioxide will be drawn in from the corrugated tube and there will be rebreathing. Like I said before, during expiration, there is a fresh gas flow from the inner tubing as well as the alveolar gas rich in carbon dioxide, which will fill the corrugated tubing. So if the fresh gas flow is high, during the next inspiration, the patient will have less rebreathing. During the expiratory pause, there is no expired gas containing carbon dioxide coming from the patient, but the fresh gas flow will still be there. So it will push the carbon dioxide rich expired gas away from the patient end. So during the next inspiration, the patient will breathe in whatever air is present in the corrugated tubing as well as the fresh gas that comes from the inner tube. The fresh gas flow to maintain normocardia during spontaneous respiration in vein circuit is about 100 to 300 ml per kg per minute. That will come to around 1.5 to 3 times the minute volume of the patient. During controlled ventilation, the mechanism is pretty much the same, except during inspiration, the bag is squeezed to ventilate. So the pressure within the corrugated, within the veins circuit increases. The expiratory valve opens because of this, and the contents of the corrugated tube, which contains the carbon dioxide, is discharged into the atmosphere. The fresh gas flow to maintain normocardia in controlled ventilation is 70 to 100 ml per kg per minute. Factors causing rebreathing, prolonged inspiratory time, high respiratory rate, adding an inspiratory plateau. All these three factors will not allow for enough expiratory pause. So fresh gas flow will not push the carbon dioxide rich expired gas away from the patient end. And if the fresh gas flow is much lesser than the minute volume also, there is chances of rebreathing. So allowing an expiratory pause reduces rebreathing as it allows the fresh gas to push out the expired gas from the corrugated tubing. What are the merits of vein circuit? It is lightweight. So there is minimal drag on the endotracheal tube as compared to the McGill circuit. It's a low resistance breathing system. And as the outer tube is transparent, it is easy to detect any kinking or disconnection of the inner fresh gas flow tube. It can be used both during spontaneous and controlled ventilation. So it's called a universal circuit. It is useful where patient is not accessible as an MRI suite. Exhaled gases do not accumulate near surgical field, so risk of flash fires is less. Easy for scavenging of gases is the APL valve, or the exhalation port is at the machine end of the circuit. It is easy to connect to a ventilator, and there is some warming and humidification of the inspired fresh gas by the exhaled gas present in the corrugated tubing. Demerits. Due to multiple connections in the circuit, there is risk of disconnections. Wrong assembling of the parts can lead to malfunctioning of the circuit. Theater pollution occurs due to high fresh gas flow. Increased cost due to high fresh gas flows. There can be kinking of the fresh gas supply, inner tubing blocking fresh gas supply, which can lead to hypoxia. There can be crack in the inner tubing causing leakage. It cannot be used in patients weighing less than 20 kgs. Pre-use check for vein circuit. General inspection. General inspection of the outer tube, inner tube, and the APL valve, as well as the reservoir bag, should be done to look for any disconnections, any defects. To check for APL valve, the patient end of the circuit is occluded. APL valve is closed, and a flow of around 4 to 6 liters is kept to increase the pressure within the circuit. The reservoir bag will inflate, during which you can check whether there are any leaks in the reservoir bag. It also confirms the patency of the outer tube. Then you open the APL valve, and the bag should deflate easily once the valve is opened. This will tell whether the APL valve is functional or not. To check for the functioning of the inner tube, there are two tests: the Fox-Crompton-Smith test and the Petix test. In the Fox-Crompton-Smith test, a low flow is set on the oxygen flow meter, and the inner tube of the circuit is occluded with a finger or a pen at the patient end. If the inner tube is intact and correctly connected, the flow meter indicator or the bobbin will dip. Petix test. Here, similar to how we check the APL valve, the patient end is occluded. Low flow is kept on the flow meter, and you allow the reservoir bag. APL valve is completely closed, and the reservoir bag is allowed to inflate. Then you oxygen flush, activate the oxygen flush, and the patient end should be let off at the same time. Due to Venturi effect at the patient end of the circuit, because of the high flow at the patient end, it will create a negative pressure in the outer corrugated tubing. This will suck the gas from the reservoir bag and the bag will deflate. If this occurs, it ensures that the inner tube is intact. If the inner tube is not intact, this maneuver will cause the bag to inflate slightly. Thank you.
Thank you, Shreya, for enlightening about our essential anesthesia equipment in our armatorium. And it is such an easy and small equipment which is universally has to be used in every either OT, ICU, or moving a patient from one OT to other ICU or elsewhere. Yes. Now we have Dr. Chandrakala, who will simplify the complex topic of uptake and distribution of inhaled anesthetics. Now over to Dr. Chandrakala. The questions will be taken at the end. Huh? Okay. Now, Chandrakala, you can share the screen.
Good evening, one and all. Thank you, sir, for introducing the topic as a complex topic. Yes, it is, though, but it's a very important topic. I would like to, first of all, I would like to thank Dr. Meenakshi Sundaram, sir, the organizers, ISA Puthukkottai branch, for giving me this wonderful opportunity to speak on this webinar. And I also thank our HOD, Dr. Netra Madam, and Dr. Raghavendra, sir, for moderating this webinar. Myself, Dr. Chandrakala. The topic given to me is uptake and distribution of inhalation.
Ma'am, I would like
can-
to request you, can you please try making the PPT in full screen?
Full screen.
Yes, yes. Okay.
Screen. Share screen.
Ma'am, your screen got stopped sharing.
Yes, yes. One second.
Red
Good
button
evening,
on the right
everyone.
corner.
Yeah. I've done it, sir.
Ma'am, there is a slideshow option. You can click on that slideshow option on the above ones.
I have shared full screen.
In case you can't.
Red button in the right corner.
Few slides.
Resume.
Yes, yes, sir. Good evening, one and all. Today, I'll be talking about uptake and distribution of inhalational agents. I'll take you people through the pharmacokinetics, the uptake, distribution, elimination, and the factors that are affecting at each step. Now, what is an inhalational agent? An inhalational agent is actually a chemical compound, either a volatile liquid or a gas, which possesses general properties, that is, general anesthetic properties, and is primarily used in the operating room through inhalation to induce and maintain general anesthesia for performing surgical procedures. These are the commonly used inhalational agents. The most commonly used in our clinical practice is isoflurane, sevoflurane, desflurane. This is in the order of discovery. Xenon, thou being a very good anesthetic and with good potency, but due to the production costs, not very popularly used.
Dr. Chandrakala, sorry to intervene.
Yes, sir.
You go to the slideshow mode, please.
Yes, sir.
It's on red button, the
Sir,
right corner.
also, ma'am, also the slides are also not moving as we can't see the slides in the moving, ma'am. We still are seeing only the first slide.
See, you have to
Okay.
go to the slideshow, then only it will move.
Yes, sir.
Share slides.
Share slides. I'm sharing now, sir. Sharing. And yes, I hope.
Yeah.
Now
Now
go
go
to
to the
slideshow. Now go to slideshow. Click the slides. Fine.
yes.
Yes, sir.
Right.
Yeah, that had got stuck.
Thank you.
Okay. What is an inhalational agent? An inhalational anesthetic agent is a chemical compound, either a volatile liquid or a gas, which possesses general anesthetic properties, which is primarily used in the operating room through inhalation to induce and maintain general anesthesia for performing surgical procedures. These are the agents in use. The most commonly used agents are isoflurane, sevoflurane, and desflurane. As I said, xenon, though a very good anesthetic, it is not very popular for use because of the production costs. The absorption phase that we see in IV is equivalent to inhalation agent. We call it uptake. The metabolic phase is designated as distribution, and the excretion phase is called the elimination phase. All these inhalational agents are referred to as gases because they are in gaseous state when administered to the lungs. And these agents are all non-ionized and have a very low molecular weight, which allows them to diffuse rapidly across all the barriers. Coming to the theories of mechanism of action, during 1870s, there was unitary theory of narcosis proposed by Claude Bernard, but it could not explain all the mechanism of action, and hence Mayer and Overton, which was more popular, became ready to explain all the actions of inhalational anesthetics. However, some halos were left, and even this theory could not explain the hypothesis of mechanism of action of these agents. And many more theories came up with explanation for action on protein receptors, ligand-gated channels, and GABA and NMDA receptors. And there was one theory which was called critical volume hypothesis theory, which actually said that inhalational agents alter the lipid membrane and execute their action through this altering of the volume of the membrane. And in the recent past, there is a role of two-pore domain potassium channel theory, according to which the inhalational agents enhance the activity of these potassium channels, causing hyperpolarization and the capability of generating an action potential. Now, again, as I said, these are all theories. There is yet more to be discovered in the action of anesthetic agents. During general anesthesia, a known concentration of anesthetic gas is usually administered via anesthetic circuit through ventilation to the patient. And that is why the uptake and distribution is very well understood by knowing the dynamic and mechanism of action and the direction of flow of the gases. Now, this is one side of the explanation. Now, there are other theories regarding the mechanism of action. At the microscopic level, there are theories that say, the general anesthetic agent acts on the spinal cord, the presynaptic and postsynaptic junction, and the molecular level on the alpha receptors of the GABA subunit complex, These are again the proposed mechanism of action. Let's come to the uptake and distribution proper. Now, when we start anesthetizing a patient, we start with a set dial concentration, which begins with the vaporizer. The anesthetic agent moves from the vaporizer, and along with the fresh gas flow, it enters the circuit. Along with a set flow, it enters the circuit, and from the breathing system, it enters the patient's airway, and from there into the alveoli, then arterial blood. Here it crosses from the alveoli to arterial blood and then enters the circulation, gets distributed to various body organs. Let's slowly move from one point to another. The same, I'm representing a pictorial diagram. Initially, we start with the set dial concentration on the vaporizer. Then we set a flow, either 100% oxygen or air oxygen mixture with or without nitrous oxide. These mixture of gases come out of the anesthesia machine through what is called as common gas outlet. We can see that connecting tubing from the machine into the circuit, that is the common gas outlet. The gas which emerges from here is designated as the fresh gas flow. This fresh gas flow enters into the breathing circuit, and there is already some amount of air present in the circuit. So this fresh gas flow gets diluted within the breathing circuit, and the composition of this changes because of the dilution here, and then it enters the patient's airway. When it enters the patient's airway, it is called as inspired gas concentration. The anesthetic agent here is referred by something called inspired gas concentration because the composition in the Fi is not same as the composition within the fresh gas flow. That happens because of this circuit dilution. Once it enters to the lungs, there is a concentration that builds up within the alveoli, and because of this concentration, there is creation of a partial pressure gradient because still it is one side. That means the inhalational agent is building up in the alveoli and the blood still has zero anesthetic agent. So now because of the concentration gradient, it crosses into the blood and then it is taken to the target site, either brain or liver, depending on the blood supply. Then after the tissue takes up the anesthetic agent, the venous return, it's not that 100% of the agent will be taken up by the tissue. So the remaining anesthetic agent is returned back through the venous blood into the lungs, and from there the elimination happens. This is a general overview of how the flow of anesthetic gases happen, and the entire flow is totally physics and based on partial pressure gradient. Now, before understanding the uptake and distribution, we'll just get the keywords right. What is fresh gas flow? As I said, the fresh gas flow is a controlled mixture of gases and the anesthetic agents which is delivered into the breathing circuit from the anesthesia machine through the common gas outlet. The partial pressure of a gas is the portion of the total pressure contributed by one component of the gas within that gas mixture. This determines the pharmacological effects of that gas. The inspired gas concentration, that is Fi, the concentration of the anesthetic agent in the gas mixture being inhaled by the patient. The alveolar gas concentration, or Fa, capital A, it is the concentration of various gases which are present in the alveoli. It creates a partial pressure gradient due to its concentration, and the concentration of anesthetic agent once it crosses into the arterial blood is represented by Fa and P small a for the partial pressure gradient. The blood gas partition coefficient, it is the ratio of an inhaled anesthetic agent concentration in the blood to its concentration in the alveoli at equilibrium. The concentration gradient is the difference in the concentration, or more accurately, it is actually the partial pressure between two regions, for example, either between two tissues, blood and alveoli, like that. The partial pressure gradient of a gas is the difference in the pressure exerted of that gas between two areas, like alveoli in the lungs and the blood, or the blood and in the tissues. The pressure difference, that is the gradient, drives the movement of the gas, with the gas always diffusing from area of high partial pressure to the area of low partial pressure. This is upstream to downstream, we call, to achieve an equilibrium. And the concentration of any gas is directly proportional to its partial pressure. The goal of inhaled anesthetics is to achieve a equilibrium between the partial pressures of various compartments, starting from the fresh gas flow up till the effects side, that is central nervous system. The factors affecting the uptake of inhalational agents are the alveolar concentration of inhalational agents and the drug uptake from the lungs. Basically, it's the delivery versus uptake. Now, this alveolar concentration is in turn determined by inspired concentration, alveolar ventilation, and functional residual capacity. The inspired concentration is determined by the total fresh gas flow, the breathing system volume, and the circuit absorption. We will go through all these one by one. And the drug uptake from the lungs is dependent on the solubility, the pulmonary alveolar blood flow, that is again dependent on cardiac output, the pressure gradient between the alveoli and the venous blood, and few gas effects like second gas effect. The fresh gas flow, as I said, it is the flow which is coming out from the outlet. The fresh gas flow is determined by two things. The composition of the FGF is determined two things. One is the flow meter or the concentration dial settings on the vaporizer, and the flow meter which keeps the fresh gas, amount of fresh gas that is entering. Together, this mixture directly enters the circuit and it fills the circuit before entering the alveoli, and it determines the Fi, that is the composition of the inspired gas concentration by the patient. So the higher the fresh gas flow, the faster will be the induction, because quickly it fills the circuit volume, and lower the fresh gas flow, slower the induction. Now coming to the inspired concentration of the agent. When the fresh gas flow comes out of the machine, it has to fill the circuit in a certain time, and the circuit has certain volume. So the Fi depends on the amount of fresh gas flow, the rate, and the circuit volume, and if at all any adsorption is happening in the circuit. For example, the rubber tubings and the soda lime canister can have a adsorption coefficient. However, the currently used plastic or silicone tubings have very negligent absorption, and hence it can be virtually neglected. We can understand this circuit filling by the fresh gas flow by an entity called time constant. What is this time constant? It is the time required for the flow through a container to equal the capacity of the container. It's given by the formula total volume divided by fresh gas flow. Now let us understand this concept through a diagram. On the left hand side above, we are seeing that the volume of a circuit, if I have a circuit with volume of 6 liters, and if I have adjusted the flow rate of 6 liters, then the time constant will be 6 divided by 6, that is 1 minute. This is called one time constant. And according to the time constant law, it takes 1 minute is equal to one time constant here. It takes one time constant for the air within the circuit to be replaced by any fresh composition by 68%. That is one time constant. If I calculate for two time constants, then almost 86% of this existing air is removed and it is replaced by a new mixture. And three time constants, 95%. And by the end of four time constant, 98% of the existing old gas in the circuit is removed and is totally replaced by the fresh gas flow. Now what happens if I reduce the flow by half? You can see in the below slide. If the flow is reduced by half, then now the time constant is doubled. That is 6 liters of the circuit, liters is the flow. 2 minutes is one constant. That means if I have to achieve the same 98% concentration within the circuit, now the time constant is 8 minutes. So the time is almost doubled. And in the same way, if I halve the circuit volume and increase the fresh gas flow, then the time constant reduces. That means quickly we can fill the circuit. So what is desired is a circuit with very low volume and a higher fresh gas flow and a circuit with least absorption. So this will equate to a faster induction. Where all do we apply this? As time constant becomes very longer in case of low flow anesthesia, we have three phases there. So initially we keep a higher fresh gas flow for a quicker induction, and the same during emergence. During the recovery phase again, higher fresh gas flows are instituted. And for priming the circuit, and then different anesthesia machines can have different circuit volumes, which affects the time constants even at the same FGF, fresh gas flow rate. So this usually we have to read the manual to know the actual volume, or you can actually calculate the circuit volume by summing up the individual components volumes, like the circuit volume plus the soda lime canister plus all the corrugated rubber tubings extra connections what you are using, everything to be summed up. And sometimes to know the time constant for lungs, we'll have to use tidal volume plus functional residual capacity to calculate the time constant. However, all this headache is not there in the modern anesthesia machine, because here we have end tidal control, which can automatically adjust the rate to compensate for these factors and keep the target concentration more steady. The factors that can affect alveolar concentration, alveolar fraction of the anesthetic agent, is one, inspired concentration, which we discussed just now, and the anesthesia uptake into the pulmonary circulation, the ventilation, concentration, and second gas effect. Other factors like dead space and shunt, which is very negligible in the healthy adult but becomes important in case of a pathology. FI we saw just now, anesthesia uptake into pulmonary circulation. Now, as and when the anesthetic agent is taken across the alveoli into the blood, the concentration of the anesthetic within the alveoli falls down. This needs a constant replacement by the delivered gas mixture to keep a constant FA, that is alveolar concentration. But the more and more agent is taken up by the pulmonary circulation, then there is a fall in the FA. This is very obvious in case of agents which are highly soluble into the blood. So in this case, the rate of build of pulmonary alveolar concentration is not equal to the circulation, and there will be delay. If there is no uptake from the pulmonary circulation, for example in least dissolving gases, then quickly the agent will reach the target site and quickly it is replaced into the alveoli also. The effect of ventilation, the rate of ventilation definitely influences the alveolar concentration. If the rate is more, then more and more gas is supplied, anesthetic agent is supplied into the alveoli, providing it easy to cross over, and hence the induction becomes faster. If the rate is less, the induction is much slower. Now, what is this concentration and second gas effect? Now let us understand this concept with a gas like nitrous oxide, which is less soluble. First, when we give the first breath of the mixture containing oxygen and nitrous oxide, the nitrous oxide occupies the bulk of the alveoli. And this being more diffusible, quickly diffuses across the alveoli into the blood. However, the volume that was there in the alveoli is suddenly lost, thus reducing the, almost like the alveoli shrinks. So suddenly the size of the alveoli is reduced, but there is no fall in the partial pressure of the gases. Why? Because relative concentration of these gases, now it is compensated for this shrink in the alveolar size. So relatively partial pressure remains the same, but the volume of the alveoli has shrunken. Now, when the next breath adds on, this is called concentrating effect, because the concentration now is more. And along with this, when the next gas enters, it carries more inhalational agent into the alveoli, and now there is more of molecules of this inhalational agent. So the gas increases the concentration of itself due to alveolar shrinkage. So this process is called concentrating effect. Now, what is second gas effect? Whenever nitrous oxide is diffusing, it helps in the buildup of partial pressure and diffusing of the other anesthetic agent across alveoli, and this happens at a faster rate in the presence of nitrous oxide when compared to in the absence of nitrous oxide. This is called second gas effect. The effect of pulmonary dead space and shunt. The dead space ventilated but not perfused. This effect is seen in case of low solubility agents. So this effect will be obviously made out whenever the agent is having very less solubility in the blood. The induction becomes obviously slow. In the alveoli, which is perfused but not ventilated, the rate of rise of alveolar concentration is slowed. So actually theoretically it should be faster, but because of uneven ventilation, perfusion and VQ mismatch, anywhere the induction becomes slower. Effect of ventilation we saw. What is FA-FI ratio? It is the ratio that indicates how quickly the concentration of the anesthetic in the alveoli approaches the concentration being delivered from the anesthesia machine towards the patient, that is FI. The faster this ratio approaches 1, the faster the speed. So this again depends on the alveolar ventilation and the inspired gas concentration and the functional residual capacity of the patient. Uptake by the pulmonary circulation. Diffusion of gases across the alveoli is called the uptake, which depends on the partial pressure gradient between the two, and the uptake of the anesthetic agent causes a fall in the alveolar concentration within the alveoli, as I already told. If there is no uptake, then the alveolar concentration remains steady. There are factors that affect the uptake from the pulmonary circulation into the blood across the alveoli. These are blood gas partition coefficient, the cardiac output, which is nothing but the blood flow that is entering the lungs, and it determines the amount of anesthetic absorbed, and the concentration gradient between the alveolar gas and the venous blood. So the pressure difference between these two gases here. We'll understand what is blood gas partition coefficient. It is defined as the ratio of an inhaled anesthetic's concentration in the blood to its concentration in the air that is there in the alveoli at a given equilibrium. It simply tells how much affinity the agent has got for either blood or the gas. So for example, and it is a measure of the anesthetic's solubility, and an agent with higher coefficient, that means it has higher solubility within the blood and it is slow in induction. Why? Because the agent which is taken up gets dissolved within the blood, and the buildup of the concentration within the target site like central nervous system becomes very slow, because more and more agent is taken up by the blood and it is dissolved, and it needs lot of agent to be dissolved in the blood before it enters the target site. Let me explain this more using agent like halothane. Halothane has got a blood gas solubility coefficient of 2.4. That means to say, at any given point, 1 ml of the blood contains around 2.4 times the dissolved halothane when compared to the 1 ml of air in the alveoli. So that means blood contains more. So what happens now, if the brain has to get halothane, then 2.4 times the amount of halothane should be dissolved to reach the required MAC there. So this is how it slows the induction. While agent like nitrous oxide, where the Bg coefficient is just 0.4, that means very negligible, very negligible amount taken up by the blood. This quickly attains the effect site concentration within the brain because it is not at all soluble in the blood. Cardiac output. Higher cardiac output means more blood flow into the lungs and lower FA, because the agent is constantly taken up from the alveoli. So the rate of rise of alveolar concentration is very slow, because inhalational agent cannot meet the required pressure so quickly that it is taken up by the blood. So in the alveoli, it cannot be on par with that. This slows the induction. And this is again more pronounced in case of highly soluble agents. Reduced cardiac output increases the uptake at a steady state, and hence there is faster induction. Pressure difference. Initially, see, when at the beginning of the induction, there is so much of anesthetic agent within the alveoli, while on the other end, venous end, there is still zero uptake. No anesthetic agent has crossed the alveoli into the blood. During this happens usually during induction. So there is a high difference of partial pressure and the concentration across the membrane. That is, there is more anesthetic agent within the alveoli, but in the venous end, there is no. So there is a huge partial pressure difference, and this help rapid uptake and faster induction in the initial stages. That too, this effect is pronounced only if the agent is less soluble. And as time progresses, more and more agent is taken, and as the tissue reaches equilibrium, the rate of uptake by the tissue decreases, and hence the venous blood now has more agent which returns back into the lungs. So now the PA by PV reduces. So the rate of uptake, that means the rate of capture of the anesthetic agent from the alveoli into the blood, slows down. It does not become zero unless there is a total equilibrium, but it slows down because the rise in the tension in the venous blood is more now. The during recovery phase, when the delivery of the anesthetic agent is stopped, then suddenly the FA, that is the concentration in the alveoli, falls, and therefore the alveolar pressure gradient that totally reduces or quickly falls down. Now the gradient is reversed because now the venous return, that the venous blood which is returning to the lungs has more anesthetic agent which is coming from the tissues. Now this is returned to the alveoli for elimination. So this reverse gradient is what helps in elimination. And all these agents, like the uptake and crossing over, are influenced by tissue solubility, the partial pressure gradients, and the physical properties of the agent. In the tissues, what happens? So now the agent has crossed into the blood and it is distributed into the tissues. What are the factors that can affect the distribution of the agent into the tissue? One is the tissue specific blood flow. Is it a vessel rich or is it a vessel poor? So how much blood is reaching the tissue? And the partial pressure gradient between the arterial blood which is going to that tissue and the pressure gradient within the tissue itself. And the effective volume of the tissue, that is anatomic volume, and along with it's a product of anatomical volume and the tissue blood partition coefficient. Now this is again depending on the solubility of the agent. Let us understand this better with a Mapleson analog. So this the tubings represent the breathing system, and the vessels here they represent the reservoir groups of various tissues. So the various tissues are divided into 4 groups depending on the amount of blood supply they get. The vessel rich group, like the brain, spinal cord, then liver, etc. Then moderately vessel rich group, that means the blood supply what they receive is lesser than that of vessel rich group. However, they contribute in a significant amount for the capacity of the anesthetic agent to be absorbed. So this is the muscle group. And the fat group acts as the largest reservoir for the anesthetic agent. However, the blood supply to the fat group is very, very less. So this suddenly when the agent enters the blood, it preferentially enters the vessel rich group because of the increased blood supply to these groups. And there is a last group, that is the bone and cartilage group, that is virtually with very poor blood supply and does not receive any anesthetic agent. The rate of uptake of the anesthetic agent into the tissues depends on the blood supply to that tissue, and it's a product of the tissue blood partition coefficient and also the partial pressure difference between the blood and the tissue. So if the agent is highly soluble, then more of it gets concentrated in the tissue and the induction gets prolonged. And the recovery phase are also delayed because the agent leaves the tissue very slowly. Yeah, as I said, higher the blood tissue partition coefficient, it is highly soluble in the tissue relative to blood. So the implication is it needs a higher equilibration time, and a prolonged or slow induction will happen. The elimination. Exhalation, nearly all the factors that govern the rate at which the anesthetic agent enters into the patient's lung and into the brain, the effect side, that is the brain, all the same factors govern the exhalation in a reverse way. So, whenever we discontinue an inhalational agent, first, the inspired fraction of anesthetic agent in the alveoli drops and the gradient is reversed. So this reverse in the gradient throws more anesthetic agent into the alveoli. The fall in the venous partial pressure takes more and more from the tissue and the tissue concentration falls. The factors, again, other factors that influence are solubility, cardiac output, tissue perfusion, minute ventilation, concentration, and partial pressure gradients. Redistribution negligible. The inhalational agents, metabolism in tissues is very minimal. However, they are mostly metabolized in the liver and excreted in the kidney, and they result in the biotransformation, results in the formation of toxic byproducts, which exerts various toxic side effects like halogen hepatitis or the fluoride toxicity. Higher the solubility of the inhalational agent, the slower will be the recovery because of all the factors what we saw now. A word on diffusion hypoxia or the Fink effect. As we all know, nitrous oxide is more diffusible and across the alveoli. So during induction, so much of nitrous oxide enters the blood. After the agent is discontinued, it suddenly comes back from the circulation into the alveoli, virtually replacing all the other gases present within the alveoli. So this transiently causes a fall in the oxygen concentration within the alveoli, and it is dangerously evident in patients with poor oxygen reserve. So how to combat this? It is by administrating 100% oxygen when we discontinue nitrous oxide. A word on MAC. Minimum alveolar concentration. Actually, this is it indicates the depth of anesthesia. So MAC is defined as the minimum alveolar concentration at steady state of inhaled anesthetic at 1 atmosphere pressure that prevents movement like withdrawal in response to a standard surgical stimulus or a surgical incision in 50% of the test population. And it is also a measure of the potency of the inhalational agent. Lower the MAC, the more potent the agent is. There are variations of MAC, MAC awake, unawake, bar, MAC 95. I'm sure you all know that. I thank once again the ISA Puthukkottai branch and all the organizers for giving me the opportunity to speak. These are my references.
Yeah. Thank you, Chandrakala, for simplifying such a tough topic. And I want to add upon that with this sound scientific concept, which has to be translated onto the clinical practices. By doing so, we can avoid, it can become, anesthesia can become more and more economical, and we can avoid OT pollutions with having this knowledge about this uptake and distribution of inhaled anesthetic. And also we can utilize this into getting a adequate depth of anesthesia, neither deepen deepen the anesthesia or overdosing or underdosing the anesthesia. We can, having this sound knowledge can make us fine tune our anesthesia skills so that the patient is not so hemodynamically unstable. And also there is a with this knowledge we can say that there is no scope for switching over of one anesthetic to another, as seen by some postgraduates doing it. So for initially they keep one anesthetic and followed by switching to another anesthetic. So this cannot happen during this kind of having this knowledge. And I just emphasize that this scientific knowledge has to be translated onto the clinical practices. Yes, Chandrakala, it was a very nice, informative session. And we now call upon Dr. Sumaiya for presenting her topic on Sugamadex, which is a wonder drug which is recently more marketed nowadays. And yes, it is a wonder drug. Yes, to highlight upon that, we have Dr. Sumaiya.
Good evening, everybody. I am Dr. Sumaiya, Anesthesia Professor, Assistant Professor in Department of Anesthesia, BMCRI. At the outset, I'd like to thank Dr. Meenakshi Sundaram sir for providing me an opportunity to speak in this webinar. I would also thank Dr. Nedra SS ma'am, our HOD, Department of Anesthesia, BMCRI, and also thank Raghavendra sir, our associate professor, providing the introduction for me. So why are we actually doing this session? So there's always a risk of residual blockade or a residual curarization seen in almost 50 to 60% of our patients. So why this wonder drug? Why is this called wonder drug? We'll be seeing in our presentation henceforth. So I would like to start with the case report of a 38-year-old 56 kg male patient scheduled for lumbar discectomy under general anesthesia. Induction was achieved with 100 milligrams of propofol, and endotracheal intubation was facilitated with 30 milligrams of rocuronium. At the end of surgery, which lasted for about an hour and a half, inhalation agents were turned off and oropharyngeal suctioning done under direct vision and was reversed with appropriate doses of neostigmine, that is 3 milligrams, and 0.4 mg of glycopyrrolate, and the patient was subsequently extubated. But after a few minutes of extubation, patient had difficulty in breathing and jerky movements. And why was this so? So here you can actually tell that the patient had residual paralysis or inadequate reversal. So that is where Sugamadex comes in, and we will be knowing more about Sugamadex now. So I would like to speak on these outlines: introduction, mechanism of action of Sugamadex, pharmacokinetics, dosing, side effects, precautions, and eligibility, and Sugamadex and special considerations. Now coming to why do we need Sugamadex? Because we need for reliable, rapid, complete reversal of neuromuscular blockade. Limitations of reversal agents like neostigmine, like slower onset of action, muscarinic side effects, incomplete reversal in deep blocks or deep phases of the block. Sugamadex offers a novel mechanism and addresses many clinical challenges. Sugamadex also is a credible alternative to anticholinesterase in anesthesia, and the use of and also it helps us use rocuronium as a substitute to succinylcholine for rapid sequence intubations. So what are the properties of a ideal reversal agent, or what is an ideal reversal agent? It should be efficient if given at any point in time in general anesthesia. There should be complete reversal of the blockade of neuromuscular blocking agents. It should have a longer half-life than the muscle relaxant itself. It should be used to reverse neuromuscular blocking agents, and no adverse cardiovascular side effects. It should not have any muscarinic side effects, no histamine release, does not depend on organs for elimination, no ceiling effect. It should have a faster onset of action, does not produce depolarizing block if given in excess, as seen in neostigmine. It should have a low cost, and it should be stable as a solution. Though both neostigmine and Sugamadex both don't fulfill these criteria, but Sugamadex to an extent fulfills almost 80% of these criteria, And that is why we call Sugammadex as an ideal reversal agent. So what is this Sugammadex? Sugammadex is actually a gamma cyclodextrin. That means what is a cyclodextrin? Cyclodextrins are oligosaccharide compounds made of glucose molecules which are interlinked with hydroxyl bonds or 1,4-glucoside bonds. And they form a donut kind of a structure. I'll show you the picture as well. It contains 8 identical hydroxyl chains bound together to create a ring or a hydrophobic core and the hydrophilic outer surface. The three-dimensional structure of Sugammadex resembles a donut with a hydrophilic exterior and a hydrophobic center. It allows encapsulation of aminosteroid neuromuscular blocking agents, particularly studied in detail rocuronium with greatest affinity, followed by vecuronium and then pancuronium. Each molecule of Sugammadex encapsulates or neutralizes one molecule of rocuronium. That is, 1:1 association is there. Now, it has two main mechanism of actions. Firstly, on entering the plasma, it encapsulates the circulating aminosteroid, rendering it inactive. Later, they form very tight bonds, that is by van der Waals forces or hydrogen ion bonding and hydrophobic interactions. This rocuronium and Sugammadex forms an irreversible complex, water-soluble complex, which is excreted in kidney. So once it's excreted, the free rocuronium is excreted. There's a creation of this plasma concentration of free neuromuscular blocking agents and a change in concentration gradient. That is, in the plasma, the rocuronium decreases, whereas from the neuromuscular junction, it increases. So it shifts. That is, the rocuronium shifts from the neuromuscular junction to the plasma, and there in the plasma, again, rocuronium is neutralized by Sugammadex. So once free neuromuscular blocking drug moves from the muscle tissue compartment to plasma, these are encapsulated by plasma Sugammadex, which maintains the concentration of free neuromuscular blocking drugs in plasma. This fuels the cycle. So it's a constant cycle. And the rapid decrease in concentration of these neuromuscular blocking drugs at the nicotinic receptors helps in the regeneration or the activity of the muscle to resume. More and more drug or more and more rocuronium comes to plasma, gets neutralized by Sugammadex, and more and more acetylcholine acts at the receptor, that is the acetylcholine receptor, and thereby muscle function resumes. So this is the mechanism of action of Sugammadex. So here is a pictorial representation. This is the hydrophilic exterior and a hydrophobic core. This rocuronium molecule gets encapsulated or engulfed in the Sugammadex molecule, and this forms a water-soluble compound or complex and is excreted unchanged in kidneys. So thereby facilitating rapid recovery of neuromuscular function without any cholinergic side effects. Now coming to the pharmacokinetics and dynamics of Sugammadex. Sugammadex rocuronium inclusion complexes have a very high association constant, that is almost like 107 moles per liter. This high association constant means the affinity of the molecule is very high, but the dissociation of this molecule is very low. That is, Sugammadex has a very high affinity towards rocuronium, and the dissociation will be only 25 million in one. That is, if there are 25 Sugammadex and rocuronium exclusion complexes, only one complex dissociates, and this is considered irreversibly fixed. In healthy adult population, so gamma dex has an estimated volume of distribution of around 11 to 14 liters and an elimination of around 2 hours and a clearance rate of around 88 ml per minute. It is also not metabolized and is excreted almost exclusively unchanged by the kidneys, and more than 90% being renally excreted within 24 hours. And the metabolism of rocuronium, or whatever this reaction or mechanism of Sugamadex, is independent of the pH and the temperature of the body. So at reversal, we see many patients having hypothermia, many patients, having acidosis as well. Prolonged surgeries may have acidosis. So the metabolism of Sugamadex is not dependent on pH or the temperature of the body, which again makes it one of the ideal reversal agents. Coming to, before me going to the dosing of Sugamadex, I would like to touch upon a few things about what is residual curization. This is in particular for the postgraduates attending. What is residual curization? What are its implications, and how do we combat, or how do we overcome this residual curization? We will see in our subsequent slides. So residual curization is also known as postoperative residual curization. It is incomplete recovery of the muscle function after the use of neuromuscular blocking drugs during general anesthesia. A definition being a train-of-4 ratio of less than 0.9. That is, the twitch height of T4 to the twitch height of T1 is taken as the TOF ratio of less than 0.9 is the definition of post-operative residual curization. There are several studies which have been conducted in the past to see the incidence of this residual curization. So this is almost like a shocking high percentage of around 63.5% of residual curization is seen in patients at tracheal intubation, and 56% is seen at the arrival of the patient in post-anesthesia care units. So it is quite high. The incidence of residual curization seen in our patients is quite high. So how do we go about these? So what are the implications of residual curization? So the implication being the impaired tone and coordination of upper pharyngeal and esophageal muscles can lead to increased risk of aspiration, risk of airway obstructions, impaired phonations, impaired cough, and it can impaired respiratory muscle tone can lead to impaired ventilation and oxygenation as well. Whereas this can also lead to difficulty in breathing, difficulty in speaking, and in our post-anesthesia care units, the incidence of post-operative hypoxia is actually 63% and upper airway obstruction. In our ICU settings where we use muscle relaxants, there might be prolonged ventilator weaning and post-operative pulmonary complications such as atelectasis and pneumonia. The incidence of these postoperative pulmonary complications are high with residual curization or postoperative residual curization. That is where Sugamadex comes in. So now, why are we so much bothered? I told you, because of the residual curization, we need to have a proper neuromuscular monitoring to ensure adequate reversal and good muscle function of patients or in patients. We have a number of numerous tests like clinical tests, quantitative tests, and qualitative tests. Clinical tests like respiratory and parameters and muscle function, wherein we see sustained head lift and sustained hand grip. Qualitative evaluation, wherein we use a peripheral nerve stimulator, we see for a train of 4 count or tetanic stimulation or post-tetanic counts. I'm extremely sorry, I have a bad URI. These are all qualitative evaluations and are always subjective. So we should ideally go in for quantitative neuromuscular monitoring with devices that stimulate the peripheral nerve and also record and quantify and display numerically the evoked responses. So here are a few examples of the quantitative neuromuscular monitoring methods like accelomyography, kinemyography, phonomyography, wherein we use kinemyography most commonly, which you would have seen in your OTs. This one, wherein there's a piezoelectric polymer sensor in the groove between the thumb and the index finger, and ulnar nerve is studied here. The movement which is produced by the muscle generates an voltage in the piezoelectric sensor present over here. So, what is trainer force stimulation? Trainer force stimulation is, I'm ideally telling using the ulnar nerve with a top supramaximal twitch stimuli of a frequency of 2 Hz. That is 4 stimuli, each separated by 0.5 seconds. Tough, and then it is repeated at every 10 seconds. That is 4 stimuli of 2 Hz given at 0.5 seconds duration and repeated every 10 seconds. Here it enables us comparing T4 twitch or the amplitude of T4 twitch to the amplitude of T1 twitch. This is known as a TOF ratio. So in TOF, that is trainer force stimulation, the fourth twitch disappears first, and this accounts to around 75% of the nicotinic receptors being occupied by the neuromuscular drug or rocuronium. A train of 4 count of 3 tells us that 75%, again 70 to 80% occupied, and then 2, a train of 4 count of 2 tells us 80 to 85, and a train of 4 count of 1 tells us that around 90% of the nicotinic receptors are occupied by the neuromuscular blocking drug. That means we are in deeper level of blockade here when our TOF count is 1, and moderate level of blockade when a TOF count is between 2 and 3. And one more thing is these are different muscles which are being stimulated. Here, adductor pollicis. Here we are monitoring orbicularis oculi and corrugator superciliaris. When our upper limb is not accessible for us, we use posterior tibial nerve, wherein flexor hallucis brevis is studied and seen in TOF. The electrodes are placed over the path of the peripheral nerve. The negative electrode is placed more proximally near to the muscle, and positive electrode behind that 2 centimeters. A supramaximal stimulus of 60 milliamperes should be used. Coming to what is post-tetanic count. Post-tetanic count is wherein a very high frequency of tetanic stimulation of around 50 Hz given for 5 seconds to a peripheral nerve, followed by a 3-second pause. And then single twitches being applied at 1 Hz frequency. And we see and count how many twitches we see after post-tetanic stimulation of the nerve. A TOF count of 0 to 5 or 0 to 4 actually tells us a deeper level of blockade. Anything above 9 tells us first appearance of TOF, and then anything above that is recovery of the muscle. So a lower PTC indicates a deeper level of paralysis. So why is there, this facilitation or count when a TOF is 0, tetanic stimulation you give and the count is 0, but after that, that is post-tetanic count is because of what is known as post-tetanic facilitation. That is, after the tetanic stimulus, acetylcholine synthesis and mobilization continues for a shorter period, and there is and therefore increased immediately available store of acetylcholine when the single twitch appears. So there is this leads to an enhanced response to a subsequent single twitch. The number of post-tetanic twitches is an indication when the first twitch of train of 4 will reappear. That is, for instance, the first twitch of train of 4 generally returns with PTC of 9. Now coming to the dosing. Because there is one-to-one binding capacity of rocuronium and sugammadex, the ability of sugammadex to reverse any depths of rocuronium-induced muscular blockade. That is, even though there is deepest blockade or deep phase of blockade, you can use sugammadex at a higher concentration probably, which I'll be telling you. The dose of sugammadex required to ensure complete reversal is dependent on the depth of the block, the timing, and the dose of rocuronium. So the terminology I'll be using would be routine block, moderate block, and profound block, depending on train of 4 and the PTC count. As I discussed earlier, routine block is a train of 4 count of 2, wherein the dose of sugammadex will be 2 milligrams per kg, and the time since the TOF of more than 0.9 is 2 minutes. Moderate block is wherein your post-tetanic count is between 1 to 5 or 1 to 2. At this point also, you can reverse the blockade using a higher dose of sugammadex like 4 milligrams per kg. And also in profound blocks, wherein your TOF also is 0 and also your PTC count of 0. That is immediately or 3 to 5 minutes post rocuronium. What do you do in such instances? Like, for example, you might have a can't ventilate or a can't intubate situation immediately after giving rock. But then at that time also, it is possible to reverse your patients using a higher concentration of sugammadex, around 16 milligrams per kg body weight. You can actually reverse a deep block, which is not possible or not seen with neostigmine. So this is what it is. At a TOF of 2, you give 2 milligrams with a PTC of 1 or 2, again, which tells you about moderate blockade, you give 4 milligrams. Where there is no response to nerve stimulation, you give 16 milligrams per kg body weight. So dosing always depends on the monitoring you have, or time since rocuronium, you can say. Now coming to specific populations and sugammadex. The dose of sugammadex for elderly is same as young adults, but the onset of action might be slower because the cardiac output is reduced in these elderly patients. Pediatrics, there's routine recommendation between 2 to 17 years old. When TOF count of 2, you can give 2 milligrams per kg in children and extubate. But sugammadex is not endorsed in neonates and infants because of their different ways of their respiratory physiology, different muscle, structures. So we don't actually recommend sugammadex in neonates or infants. In pregnancy and breastfeeding, there is very minimal placental transfer, but actually there are multiple case reports wherein we've seen administration of sugammadex to women post cesarean section to overcome the residual blockade. Also, this makes sugammadex or this availability of sugammadex allows rocuronium as an acceptable alternative to succinylcholine for rapid sequence intubations in pregnant patients. And specific considerations in obesity, actually it is difficult areas where we can be using rocuronium, and the dosing is depending on ideal body weight plus 40%. Dosing based only on ideal body weight actually leads to increased risk of inadequate reversals. In neurological diseases like myasthenia gravis, which actually pose challenges to us, wherein they require lower doses and have variable duration of action, the risk of postoperative residual blockade is high in these patients. So again, Sugamadex comes in as a alternative to neostigmine. It is a safe and effective alternative to neostigmine, and it can also be used in other neurological conditions like myotonic dystrophy, amyotrophic lateral sclerosis, Duchenne's, and Huntington's disease. Like now coming to cardiorespiratory diseases, it is safe for patients with pulmonary diseases such as bronchiectasis, cystic fibrosis, or for that matter COPD, wherein neostigmine is known for increasing the secretions in these patients. And the incidence of bronchospasm also is very high with neostigmine. So Sugamadex is a very safe alternative to anticholinesterase for reversal in these patients. They also can be effectively used in patients with cardiac failure or IHD, where you don't want tachycardia as one of the side effects. In these patients, we can use Sugamadex very safely. Again, in patients of heart transplant, there might be a delayed recovery or seen in these, but delayed doesn't mean incomplete. Delayed but complete recovery. That delayed recovery might be due to decreased cardiac output per se. Renal disease, it's not used in patients with a creatinine clearance of less than 30 ml per minute. We can use hemodialysis and remove Sugamadex. Liver disease, we have not extensively studied Sugamadex and liver dysfunction, but Sugamadex is almost solely excreted renally. There's no dose reduction required in moderate or mild hepatic dysfunction. Now coming to side effects of Sugamadex, which is very minimal, hypersensitivity of 0.08 to 0.2, dysgeusia, headache, fatigue, nausea, vomiting, dizziness, urticaria, abdominal pain, prolongation of APTT, and bradycardia. Having said these side effects, the incidence of side effects are pretty much lower when compared to neostigmine. So neostigmine has well-recognized undesirable side effects like variable reversal of neuromuscular blockade. It is not able to reverse profound depth of blockade, and also given during profound or moderate level of neuromuscular blockade, neostigmine can actually potentiate or exacerbate the neuromuscular block by direct action on the nicotinic receptors. Now, interactions of Sugamadex, it is not recommended with ondansetron, verapamil or ranitidine due to physical incompatibility. And there are two reactions what we see in drug interactions, that is displacement and capture reactions. Displacement reactions is wherein the drug or Sugamadex itself displaces, that is rocuronium is being displaced from Sugamadex. That is, it causes dissociation of the complex. And there is a theoretical risk of recuriorization there. So these drugs which cause displacement of rocuronium are tormifen, fusidic acid, fluoxetine, and diclofenac. Capturing reactions is like it actually encapsulates hormonal contraceptives. So the patients who have been given Sugamadex as a reversal need to be counseled for using an alternative contraceptive method for the next 7 days post administration. So, though we say it is the acquisition cost of Sugamadex is high, but it actually helps saving the OT time. We can reverse the patients very fast. That saves the OT time. It actually reduces the mortality, like specifically in cases of like especially surgery goes ahead and you have a can't intubate, can't ventilate situation, you can give Sugamadex and reverse these patients. Also, it reduces morbidity because, again, here the accusation cost is offset by reducing the respiratory complications, reduced hospital stay because of reduced post anesthesia care unit complications like pneumonia or, for that matter, atelectasis, or delayed weaning from the ventilator as well. So, though the cost is high, the acquisition cost of Sugamadex might be high when compared to neostigmine, but all this cost is offset by the what you call effects of Sugamadex, which helps in like early recovery of the patient. Key takeaways, it offers rapid, complete, and predictable reversal of aminosteroid. It is superior to neostigmine in speed, safety, and depth of block reversal. It enables rocuronium as a safer alternative for rapid sequence intubations. There are minimal muscarinic and cardiovascular effects, dose adjustment needed for renal dysfunction, and a true game changer in modern anesthesia. I thank all the moderators, Raghu sir and Meenakshi sir, for giving me an opportunity. I hope it was a useful session for the postgraduates. Thank you, everyone.
Thank you, Sumaya. It was time now to change neostigmine to Sugamadex. One more thing about this is through the evolution of anesthesia, we might come across so many new drugs, which was more of a pharmacokinetic changes. Whereas this may be the very few drugs which has change in pharmacodynamics and new drugs which is more targeted towards pharmacodynamics. So any residual neuromuscular blockade morbidity or complication can be offset by use of Sugamadex, and it is so versatile that it can reverse all any superficial block to any deep block, moderate to deep blocks. Yes, sir. Meenakshi Sundaram, sir.
See,
Any
there are
final
some
opinion?
questions. There are some questions in the chat box.
Okay, sir.
Dr. Muthukumar Rajagopalan has asked a question. Which is the common site for inner tube getting damaged in brain circuit? Which is the common site for inner tube getting damaged?
Shreya?
So the site where the inner tube enters the corrugated tubing, sir.
Yes.
That is the site for most common site for king and getting damaged.
Then the next question is, what is your personal experience in Sugamadex usage? Have you had any situation where only Sugamadex is indicated?
We've never had such like situations where only Sugamadex was indicated, sir. We've been using Sugamadex regularly in our OTs for actually directly we have postgraduates who are doing studies on neostigmine versus Sugamadex. So we've been regularly using Sugamadex, but never had a like situation where only Sugamadex is indicated. No, sir.
That is the
Sir,
idea.
But
This question was
We had, sir, we
Can
had
I-
used in a pediatric case of around 8. It's a foreign body. It's a is of at a crickopharynx. A coin, I mean, immediately, like it was removed within no time. So it has to be reversed with in Sugamadex, and it was very smooth reversal. It has to be reversed within around 8 to 9 minutes itself, sir.
so at the time, what relaxant you will use? Rocuronium.
Rocuronium,
Yes,
sir.
yes, sir, acronym.
So how you have compared the action of Sugamadex with the neostigmine? Because you say people have done theses.
Yes, sir. We have almost like done a few case
We are
studies.
using combined. There
Chandrakala
are
ma'am
studies
actually
which
is
doing.
moderating.
Sir, today only we had a case where the patient had RHT with severe mitral stenosis and critical aortic stenosis, sir, near critical, I should say. And I didn't want to use atracurium because patient also had other like hypersensitivity history and all. So, and more than that, we had decided that we'll use Sugamadex for reversal to avoid the tachycardia and all. So we gave vecuronium as a muscle relaxant for that patient, and we reversed with the Sugamadex. Patient came out very smoothly. So that situation where only Sugamadex can, like, we decided to use nothing other than Sugamadex. So that was that situation we faced today only morning.
Because why I asked the question, see, the postgraduate should not be stumbled if it is not available, then they'll think the heaven is lost. And
Who knows?
Sumaiya madam said, our people are doing thesis. Just because you people are doing thesis, we cannot use the drugs. So at least
No,
one
sir,
point
it's
will
not
be.
that. They've been doing it, I said.
No, I have seen that ISIS boils apparatus costing 45 lakhs rupees in a hospital. I asked that because Dean happens to be an anesthesiologist. So I asked why you have purchased this. He said our people can do at least 10 studies in that for thesis. So that is the idea. Anyway, thank you. If there are no questions, I think your moderator can pass final remarks so that we can conclude the proceedings.
Right.
Yes, sir. This was indeed a honor of you are favoring our Bangalore Medical College for this webinar, sir. And I thank yourself, Dr. Meenakshi Sundaram, for giving this opportunity, and other office bearer, Dr. Hema K, Dr. Kannan, and Dr. Munian. I hope this keeps going on, make it 50 century and double century and all, so that it helps all those postgraduates and this anesthesia fraternity, sir. I also thank all of my speakers today who happens to be very good at their presentations. And also I thank our head of the department, Dr. Netra Madam, and all other senior colleagues and our respective colleagues and postgraduates in supporting to have this webinar. Thank you, sir.
Thank you, Dr. Raghavendra. Now it is my duty to formally thank all of you. See, indeed, it is indeed a real great session, and tomorrow we will know how many people have attended. And I thank the Shreya, the youngest faculty, in the today's webinar, who has elaborately discussed about this pain circuit and the problems, and Dr. Chandrakala for all pharmacokinetics of inhalation agents. And madam, it is not volatile, it is still in my memory. So I have to thank you. And the Sugamadex, in Tamil, the Sugam is happiness. So the way in which Sumaiya madam described the Sugam, it was happiness. And even all the questions, like a bowler, all the questions are bowled at Dr. Raghavendra. And as a shrewd cricketer, he has faced all the questions very well. So the full toss was taken to a sixer by him. And thanks for his pleasant moderation and the ever smiling face of all the 4 faculties. Today only I am seeing people will be tensed up, but all are having a ever smiling face and the greenish smile. So it should stay forever in your life. I wish you all the very best in your future. And I request
Thank you, sir.
Swastika Clearnat to offer the concluding remarks to conclude the session.
So, thanks to all the dignitaries present here. Clarity is really glad to have all these brilliant people together in this session today, and I really hope that you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today and looking forward to hosting again. Thank you so much, everyone.
Thank you.
Thank you, and good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.